Hello, this is Tessa Kegel, and this is HBS5 OHC Module 10b, Part 2 of 2, Identifying and Controlling Hazards, Mitigation of Health Impacts, Occupational Epidemiology. This is the Commonwealth of Australia Copyright Act 1968, which covers this series of lectures. Cause and effect. Causation can be single or multifactorial, and some causes of disease can be confounded or modified by various other factors. The strength of the evidence for some diseases is high enough for there to be very little dispute about causation. But some diseases, for example heart disease, have complex causes. Asbestos is an accepted cause of lung cancer, but cigarette smoking is a confounding factor, and lung cancer can be caused by other factors. Digoxin modifies the heart rate, but the effect of the drug is modified by the size of the person. A guide to the assessment of causation of disease in observational studies is to use the following criteria developed by Christie et al. As supporting a strong association. So first of all, we consider the strength of the association, then consistency, specificity, time relationship, biological gradient, biological plausibility, coherence of the event, experimentation, and analogy. Studies which examine the prevalence of a disease, prevalence studies, are often described as cross-sectional studies. Cross-sectional studies often use surveys to collect data, and research design relating to validity and reliability are very important. To test validity, test procedures must be compared for their sensitivity and their specificity and their positive and negative predictive value against the truth or gold standard. Reliability requires standardization of tests and observers, attention to the size and type of response rate, and awareness of biological variability, such as issues with the time of day, and statistical phenomena such as regression to the mean. Whilst cross-sectional surveys can be useful for determining the needs of a particular representative sample of a population, relationships between exposures and effects can be tricky as the measurements are collected at the same time. It is for this reason that cross-sectional studies can be the weakest of epidemiological studies. Notwithstanding this, they are a useful starting point for examining population health, and many countries routinely collect this type of data. The WHO collects, displays and stores data from cross-sectional studies in an online tool called the WHO Global Infobase. The database allows health professionals and researchers to access information on chronic diseases and their risk factors. For example, there is information on blood pressure, physical activity, diabetes, cholesterol, alcohol use, and so on for over 180 countries. Users can search for particular information and compare across countries. The WHO states, high-quality health statistics are essential for planning and implementing health policy in all country settings. The infobase assembles for the first time in one place non-communicable disease risk factors collected from WHO member states. Non-communicable disease risk factor data are crucial for predicting the future burden of chronic diseases in populations, and also for identifying potential interventions to reduce the further burden. The Infobase online dissemination tool provides not only data, but also health information to help users understand health inquiries worldwide and improve the health of nations. This resource details many health issues which include and are beyond the focus of hazardous exposure. It is a valuable resource of which you should be aware. So now we move on to case control studies. Now the most important thing with case control studies is the definition of cases and the definition of controls. So cases generally are subjects who are characterized by having a particular disease or some sort of condition, whereas controls are people who are as like them as possible but without the disease or the condition. So it's a stronger study design than the cross-sectional survey. The relative risk of getting a disease can be calculated, but as the groups are a selected group of cases and referents, not usually total populations, an odds ratio is used. That is the odds of getting a disease or a specific outcome. An odds ratio of 1 means an equal chance of having the disease whether exposed or not. As the ratio is not totally credible, except with a high odds, a 95% confidence interval is usually calculated to ensure the differences are statistically significant. Simply expressed, a confidence interval which includes 1, i.e. an equal chance of getting the disease whether exposed or not, is usually not significant. A group of workers experiencing similar problems are matched with a control group in as many ways as possible. So, for example, sex, age, occupation, and so on. Case control studies are always retrospective, i.e. the investigator starts by identifying diseased and non-diseased individuals, this is called the effect, and looks backwards for the presence or absence of exposure, so basically the causes of the disease in these individuals. If the group with problems demonstrates a particular trait, so for example, exposure to a given substance or stressor, not evident in the control group, then a link may be established with a particular chemical or biological exposure, or perhaps hazardous work practices. Ledoux, from 2007, suggests that case control studies are very useful for evaluating multiple exposures associated with a single outcome, are relatively quick and inexpensive to administer, do not impose risks on subjects, and are quicker to pick up conditions with long latency periods. As we have discussed in previous modules, the latency of many occupational diseases can be extensive. If we take asbestos-related diseases as an example, a disease such as mesothelioma is rare, has long latency, and can be studied retrospectively, examining multiple possible etiological factors. Clearly, rare exposures would not easily be studied using this methodology, as the time frame to pick up the cases would be extensive and in itself cause a bias. Case control studies also have a number of disadvantages in that they often only study one disease or outcome at a time, they may be biased by focusing on only certain factors, or there may be distortion due to the selection of cases. Stratification and randomization can be used to control some of the bias. It's not difficult to see that people with a disease will have a strong interest in recalling exposures in some detail, whereas controls may have a poor memory for other details, for exposures which they do not consider to have relevance to them. This is a really key point, and it can be easy to understand if we consider the effects of a few particular examples. So say, for example, a study of the effects of exposure to visual display terminals, computer screens, on reproductive outcomes. Women who have miscarriages and are concerned about possible environmental influences on this occurrence are more likely to have examined their work history, i.e. their hours of exposure, compared to a control group who have normal birth outcomes. It's also clear in such a study that there are confounding factors. Age of the mothers, previous history of miscarriage, smoking, and the frequent occurrence of miscarriage in the normal population are some of the possible confounding factors for pregnancy outcomes. Now we move on to another study design, longitudinal or cohort studies. Cohort studies are a stronger study design than the case control studies. They measure prospectively or retrospectively groups with exposure to possible causes of disease. For example, a cohort study may measure a group with a common experience, such as Vietnam veterans, to follow who gets leukemia and what were their exposures, or to compare groups with a variety of exposures, such as smoking or not, heavy smokers, low smokers, and those who have heart disease. Observations are made over a period of time to determine if a link exists between exposure to a chemical or other hazard and the exposed group. Such observations may be retrospective, studying personal records of people who worked in a particular environment over a number of years and following up on their present state, or prospective. A group is selected and observations continue into the future. In cohort studies, subjects are admitted without a disease and thus incidence can be established. Cohort studies are therefore useful when exposure is rare and exposure can be elicited without bias. Cohort studies can be useful also in examining multiple effects of exposures and in elucidating a temporal relationship between exposure and disease. When following a group, it can be useful to measure the effects of changing risk status over time. For example, a major study on women may look at the effects of taking the contraceptive pill and the combined effects of the pill plus smoking. It may also trace over time the effects when the dose or type of medication changes. It is of use in OHS to look at cohort and evaluate the effects of a particular exposure retrospectively. For example, a chemical, and trace the path of changes in levels of exposure over time, as well as positive changes that have been made in the workplace to decrease exposure. This method can be used to evaluate long-term outcomes of OHS interventions. There are a number of disadvantages with cohort studies as well. Cohort studies are frequently expensive and time-consuming, and there may be long delays before the results are available if the study is prospective. This may have implications if it is suspected that an exposure is dangerous. It's also difficult to maintain measures over time, and dropouts may seriously affect the results. For example, a cohort study of a population of a city may have a dropout of death or of a large number of males if there's a war, and this may give a very biased outcome of the health of that community. Biases can emerge from the movement in or out of a cohort or initial subgroup, differences that may determine the outcome. Cohort study needs strict controls to validate outcomes. Randomisation, standardisation, matching and multifactorial analyses are used to increase the validity of the results in longitudinal and cohort studies. Cohort studies are used to give us standardised mortality and morbidity rates for diseases and other conditions. Finally, longitudinal and cohort studies are used very, very commonly in occupational epidemiology. The final type of study design that we'll be considering today are randomised controlled trials. This is the strongest study design which we'll be considering, in which subjects are randomly assigned into groups which either receive or do not receive an experimental intervention. These are commonly performed when comparing various treatment regimes or treatment versus placebo trials. The randomised control study is often difficult to carry out in the community or workplace. For example, we cannot ethically allocate a group of people to exposures to a possible carcinogen. In addition, controlling a workplace is very difficult compared to a clinical trial, as the multifactorial nature of exposures and the cross-fertilisation of information between workplace groups makes it impossible to separate subjects into exposed and non-exposed groups. Investigation of disease clusters is one application for epidemiological data, which we'll consider in this lecture. Most commonly, the OHS practitioner may be consulted about this in relation to occupational cancer. This investigation process is related to disease clusters, which we've discussed in an earlier module. It's usually quite technical, and a lot of it's really beyond the scope of this subject. However, it's useful to have some basic understanding of these many issues which are considered in the analysis process. Joe Ledoux from 2007 explains clusters in relation to occupational cancer. Clusters are defined as groups of like or similar illnesses aggregated in space and time within a group of individuals with the same occupation. The first challenge is to confirm that there is indeed a cluster. A commonly encountered scenario involves the recognition by a group of workers that several individuals have had cancer. The first approach is to investigate the data further by interview of the affected individuals or by review of medical records. Individuals may have distinctly different types of tumours that are etiologically unrelated, for example, breast cancer and lung cancer. The individuals may not have shared the space for very long, or may have had cancer prior to joining the group. If initial investigation does reveal that a true cancer cluster might exist, the next step is to confirm that the observed incidence exceeds what might have been expected in a population of comparable size and demographics, i.e., that the apparent clustering did not occur by chance. One must also take into account the healthy worker effect. This assessment requires appropriate statistical methods and cancer incidence data. It is also important to assess exposure in the work area and to look for potential sources of exposure to carcinogens or other hazardous chemicals, physical agents. This concludes this lecture on occupational epidemiology. As I said, we've provided a very brief and a simple summary of epidemiology and its underpinnings of strategic occupational health and safety interventions and reviews. We've touched briefly on the types of study designs available and the literature of occupational epidemiology and broader OHS research. This should give you the basic study tools to read epidemiological texts and other OHS-related literature and be able to synthesize the information regarding hazardous substances exposures and health impacts on related worker populations. This is the end of this module. There are a number of references which were drawn on to develop this lecture. And we also have some further reading for you. There are a number of journals and websites which specialise in epidemiology. The Scandinavian Journal of Work Environment and Health, Occupational Environmental Medicine, which is another journal, probably the top journal in terms of occupational epidemiology, American Journal of Epidemiology, the United States Department of Labor. They have a site which is specifically on epidemiology. If you go to the OSHA page and search epidemiology, it will take you to that site. And a library of resources has been developed specifically related to global health and prevention, focusing on epidemiology, and it's called the Super Course and was developed by the WHO Collaborating Centre at the University of Pittsburgh. A network of over 65,000 scientists in 170 countries have contributed to the free library of 3,712 lectures in 31 languages. It's unclear if a peer review process has been applied to all the resources on this site, so you need to exercise some caution regarding accepting all the information presented as being up to date or reliable. And the website address is there on the page for you. Thanks very much for your attention with these lectures, and I look forward to discussing the content with you. Goodbye.